I'm Dr. Sunikom S from Lersin Hospital. My topic today is about management for the labral injury. What are we doing now in 2023? I have no disclosure. So why the labral tear? So isolated labral tear is rare, and patients usually have the structural abnormality, and the labral tear is an effect of these underlying problems. So we have to understand the reason that caused the labral tear first before we plan the treatment for the labral tear. As we know that the 5 common causes of the labral tear are the trauma, impingement, dysplasia, capsular laxity, or degenerative tear. And the FAI is the most common cause of the labral tear, and both forms of the FAI can cause the labral tear. And in CAM type FAI, there's a shear force from bony bump occur at the condylabral junction and can create the condylabral tear. While the pincer type FAI, there's an impaction force or crush injury directly at the labral tissue and create the intrasubstantial tear of the labrum. And why we have to refix the labrum? We have to know the anatomy and the function of the labrum regarding to the hip joint. And the labrum is the fibrocartilaginous structure that attached to the edge of the acetabulum and connect the acetabular cartilage. And the transverse ligament connect the two distal ends of the labrum to forming a complete ring. And cadaveric studies have shown that the labral is the structure that has the free nerve ending and sensory nerve supply. So it can lead to significant pain when the labrum is torn or mechanical unstable. And the labrum appears to have several important functions in the hip joints. This includes the increased hip joint stability and reduced contact stress. So let's look at the increased stability of the hip joint. The labrum helps increase the hip joint stability by increasing the acetabular depth. And moreover, the labrum also helps maintain the suction seal effect by keep the interarticular fluid within the central compartment of the hip joint. When there is a distractive load to the hip joint, this will create the negative interarticular pressure, resist the displacement of the femoral head. And labral tissue also helped reduce the contact stress of the articular cartilage by increasing the contact area of the acetabulum approximately 22%, and the suction seal effect of the labrum keep fluid within the central compartment and help distribute the load to the cartilage. There's a cadaveric study from Philippon and team compare the interarticular fluid pressure in the central compartment in each labral condition. As you can see, when you do the partial resection of the labrum, you lose the interarticular pressure from 100% to 52%. So it's quite really change the fluid mechanics of the hip joint. But when you do the labral repair or reconstruction, you can increase the interarticular pressure back to its normal state. So let's look at the treatment of the labrum injury. Once the diagnosis is established, the trial of the conservative treatment with rest, activity modification, NSAID, and focused physical therapy is attempted for first 6 to 12 weeks, and intra-injection can help confirm the diagnosis and also help therapeutic treatment, as this can reduce the pain and improve the physical therapy. From the literature, the physical therapy helps improve the patient symptom, but when compared to the arthroscopic surgery have the greater improvement than the physical therapy. When failed conservative treatment, the surgical treatment can consider, and nowadays the surgical option for the labral injury including the labral debridement, repair, reconstruction, and augmentation. And don't forget to address the etiology of the impingement along with the labral treatment. And the strategy for the labral treatment has evolved over the few decades. Early in the history of the hip scope, most patients were treated with the labral debridement only, while today the majority of the patients will have the labral repair in primary hip arthroscopy. However, the partial or complete labral reconstruction or augmentation technique have recently been developed as the treatment option for the irreparable tear. As you can see, there's a various proposed treatment algorithm for the labral injury nowadays, but the labral repair is still the main workhorse surgical option for hip arthroscopy because the labrum has many important functions that should be maintained when possible. Let's start from the labral debridement. In the early development of hip scope, most labral lesions were treated with the labral debridement, and the goal is to relieve the pain and return the patient function. And the literature report good outcome in short-term follow-up. And however, debridement, the labral tissue may cause the loss of suction seal and compromise the hip biomechanics. When comparing the labral debridement with the labral repair, Dr. Larson reported that the repair group has the significant higher post-operative outcome score when compared to the debridement group. And Dr. Kaish also found better results with the labral repair in their randomized study. However, the problem with this early study is oftentimes that you include very different patient population, that the young active patient with the healthy cartilage tissue getting the labral repair, while the older patient who has like a degenerative labrum getting the labral debridement, or the debridement cohort comprised of patients treated early in the surgeons earlier in surgeons' career experience, while the repair cohort is in the late repair experience of the surgeon. And this is the most recent study by Dr. Menge. He found that the higher rate of the revision in the total hip arthroplasty in older patients, patients treated with the acebra microfracture and the hip with the arthritis, regardless of the labral treatment. And when after he controlled the factor that related to increase the hazard ratio for the failure, he demonstrated that labral debridement and labral repair has the comparable result. So what is the current role of the labral debridement? Currently, the labral debridement can be treatment of choice for aging patient who has the minimal arthritis with the stable labral tear that does not disrupt the condylabral junction, or small tear that has the adequate tissue to maintain the suction seal after debridement, and no radiographic or clinical sign of instability or dysplasia. For the labral repair, is a gold standard treatment for labral tear. It can restore the joint anatomy to the pre-injury state and maintain the hip biomechanics. The current recommendation is to repair the labrum in the primary hip arthroscopy if the tear is unstable tear and disrupt the condylabral junction with the good labral size and good labral quality. The technique of the labral tear has variation, and some are still controversy. There are two major techniques for repair. The simple root repair, this method is simple and faster, but may lead to labral eversion and compromise the suction seal. And this technique can be used in any situation, and it should be used in situations where the labral tissue is poor. While the labral-based fixation can maintain the triangular shape of the labrum and avoid the labral eversion, and no suture articulating with the femoral head, and the labral-based fixation should not be used in the labral tissue that is poor quality, as the suture may pull through the labral tissue. When compare the simple loop repair and the labral-based fixation, Sawyer and team found no difference in the clinical result, failure rate, and revision rate. Dom also found no difference between these two techniques. If the acebuloplasty is required for the pincer lesion, but the labrum is not already separated by the tear, there is a debate surrounding whether to do the labral takedown or preserve the condylabral junction. Classically, the labral takedown has been used, and this is provided good visualization, but the incomplete healing may be occur. So nowadays, many surgeons try to preserve the condylabral junction when do the acebuloplasty, but the labrum can be damaged during we do the bone, burying the bone, or visualization is quite poor. There's a few papers that compare the result of these two methods of pincer resection. Dr. Redmond also found no difference in terms of the clinical outcome and revision rate between these two techniques. For the labral reconstruction, currently there's well-accepted indication for the labral reconstruction, which are the revision situation when the quality of the labrum is poor, non-viable labral tissue, and poor labral thickness, which is not adequate to maintain the suction seal and the labral defect. And this is the example of the irreparable tear. There are several graft options for the labral reconstruction, including the autograft and allograft, and the study currently available are unable to demonstrate the superiority of the one graft over the another technique. So the decision on graft is depend on the surgeon preference. And the technique for the labral reconstruction also vary. The segmental reconstruction means that the early irreparable segment is reconstructed and remain the healthy labrum is preserved. And this technique shows good and excellent outcome in the short, mid, and long-term follow-up. For the circumferential reconstruction, means that we resect all the labrum tissue and reconstruct it all. And theory, the advantage of this technique, there is no connection between the graft and the native labrum that might compromise the suction seal. However, this technique is quite difficult, even in the experienced hip surgeon, and there is no comparative outcome between these two techniques. For the labral reconstruction, if the labral tear is irreparable, to choosing between the labral reconstruction or treatment, in the literature, the labral reconstruction has demonstrated the superior outcome when compared to the labral treatment in the patient with the segmental labral defect in the short-term follow-up. For the labral augmentation, so this technique is to preserve the native labral tissue and incorporate the allograft or autograft tissue into the labral repair and to help with the create the suction seal. And this procedure is appropriate when there is the labral tear is still intact, intact the condylabral junction, and the tissue volume is not adequate for the recreate the suction seal. So the graft is augmented on the capsular size to help restore the suction seal. And Dr. Philippon recently compared the labral augmentation and reconstruction and found that the labral augmentation has the higher percentage of the patient who reach the like minimum clinical important difference in the augmentation group. So the take-home message, isolated labral tear is quite rare, and FAR is the most common cause of the labral tear. And the suction seal is the important role of the labrum. So whenever possible, you have to we need to preserve the labral by doing the labral repair. So, and labral reconstruction is the alternative option in the revision setting or irreparable tear. Thank you.